Hello and welcome to another show of Keeping You Informed. I'm Mayor Joseph Polisena. We come to you each and every evening at this time on this same very Bat channel, as they say. I was a big Batman fan when I was a young kid. But to the men, women, and children of all ages, this is an important show tonight. It really is. It's an issue where it could affect any one of us. Hopefully it won't affect any one of us, and you'll see what I mean shortly. I have two very special guests who've taken time out of their busy schedule to come on and explain some changes in our pre-hospital care treatment. That is, you have an emergency, you dial 911, you call a prospective fire department, they come to your house, the rescue comes to your house, the ambulance comes to your house, and obviously we're all governed under protocols. But first, I'll start off with the Chief of Emergency Medical Services, Jason Rhodes. Jason, welcome to the show. Appreciate you being here. Thank you so much. Taking time. Why don't you explain, obviously, who you are? Obviously, Jason, we know you're Jason Rhodes. Explain your background, what you actually do, and what EMS really means. A lot of people may not know what the Emergency Medical Services Division does. So.
Sure, we'll be happy to. So I work at the Rhode Island Department of Health in the Center for Emergency Medical Services, where I serve as the chief. I've been there for slightly over 6 years now. Okay. Previously, I worked in the town of Burrillville, the Harrisville Fire Department, serving as a volunteer and career EMT firefighter for 20 plus years.
Wow, so you get some experience, yeah.
Sure, and also an instructor coordinator in the field. Had the privilege of doing lots of classes there as well. So I think I bring a broad spectrum of some experience here to the office. As far as serving as the chief at the Department of Health, we serve a wide variety of functions in the health department. So first and foremost, we license people. So we need to be able to provide that privilege for people to go out onto the streets and work. So we license 3 different levels of EMTs. One is an emergency medical technician. 2 is the advanced emergency medical technician cardiac. And finally, the paramedic, which is the highest level of care. We also license the ambulance service itself and ambulances themselves. So we have purview over a wide spectrum of the EMS community. As a result of that, we also have the capability of performing compliance measures. So we will investigate any complaints that come to us, whether it's a clinical issue or a criminal issue of an EMT, because again, our primary focus is to keep the public safe at all times. So we look at those from different viewpoints on a routine basis. We also, as far as compliance goes, we inspect the ambulances to make sure that they have the proper equipment. The equipment is in working order. The vehicles are roadworthy, for example. So that's a ongoing routine process throughout the calendar year. We also have a EMS for Children program within our center. So the EMS for Children program is a little bit unique because it crosses not only from the pre-hospital emergency care spectrum, but also over to the emergency departments in the hospitals. So one of the major goals is to ensure that right now, hospital emergency departments are capable and ready to see pediatric patients, even if they're not a pediatric specialty care hospital. We recently, within the past couple of years, we have moved on to a new data collection system, which has been tremendously helpful to us. So we're meeting a national standard now called the National EMS Information System. We're actually migrating over from their version 2 data set to a version 3 data set. We are able now to provide a lot of data to external partners and use it a lot internally. So from the internal perspective, we were able to make decisions for the new protocols that we recently released that we'll talk about later in the program. So that's been very helpful. But also, with a lot of other public health issues that are going on right now, we're able to provide data to those partners. For example, the opioid crisis that's going on right now, we're able to provide some help there as well. So that's been very, very helpful. So those are some of the functions that we have.
And how many licensed EMTs do you have roughly?
So we have roughly 4,500 licensed EMTs across all levels.
Correct.
We have about 500 ambulances that are licensed, both transporting, most of what you think of as the traditional ambulance, but also fire engines and SUVs
that are licensed.
That we call them non-transporting licensed ambulances. They carry the equipment. They just obviously don't have the capability of transporting the person to the hospital. So
wow, that's a lot. And you got a staff. I know you have a very scant staff, but I mean that's as you know, I've been involved in this a long time. EMS has always kind of been on the back burner, and how important it really is. But roughly, how many people you have in your staff?
So we have 4 people full time
For 4,500 licenses. Wow.
Correct. We have a licensing aide that splits time with us,
Right.
and Dr. Williams, who's our medical consultant on a part-time basis as well.
So, Doc, now we're going to come to you. Doc, you have the honor, I should say. It's not really an honor, but maybe it is. It is to us to have you as our medical director. We obviously all respect you. You're an emergency room physician. If you would describe, you have years and years experience. You must have started when you were very young, Doc. But in the emergency medical services, but also in the emergency room. So, welcome, Dr. Williams. Thank you for taking time out of your busy schedule. I appreciate you being here.
Well, thank you for inviting me and inviting both of us to come talk about this important topic. So I am an emergency physician. That's a board-certified specialty, just like surgery or pediatrics. And I practice within a group that covers Rhode Island Hospital, the Miriam Hospital, Hasbro Children's Hospital, and Newport Hospital. We're a department within the Brown University system, and we train residents. 13 residents a year in a 4-year program. And we have a number of fellowships, including a fellowship in emergency medical services, which has recently become a subspecialty of emergency medicine. I'm also board certified as an EMS physician in that subspecialty. And I've been working with the Department of Health since about 1997. In a variety of consulting and supportive roles, trying to help the EMS system coordinate with the emergency departments and deliver the best possible care for the people of Rhode Island.
Sure. Well, as I said, I think we're very lucky to have you as, I know it's a part-time basis, but I know it's like a full-time job because you've got to deal with 4,500 of licensed EMTs, EMT, cardiac advanced, and paramedics. Let's just talk about one of the major changes, and that's why I'm very happy you gentlemen came on tonight. As you know, I mean, it's no secret, maybe the audience may know, I've been involved with EMS and been a nurse for 30 years. But back when I first got on the fire department, we had a saying, as funny as it was, but that's the way it was you call, we haul, that's all. But that's evolved now. Obviously, with pre-hospital care providers in the field now, they're doing so much more and they're saving so many lives. So I know that there were some changes, and I think that people need to know, because of course, when years ago when I was in the field, I was a fireman for about 21 and a half years, spent almost 20 years on rescue. As you know, people would say, hurry up, get them to the hospital, hurry up. But that's not what we do, or what the men and women out there do anymore. Correct, Jason? I mean, so now with the new changes that have come down, maybe you can explain the studies that were done. And as you know, Doc, you guys just don't, you don't pick something out of the air and say, we're going to do this. You look at careful research. Is that fair to say? So why don't you explain and then I'll have Jason kind of come into the new protocols for a sudden cardiac arrest, because now they're going to spend more time on scene. Is that correct, Doctor?
That's correct.
So why don't you explain basically the studies and how it all evolved, and then you guys can jump in.
Sure. That was a good description of some of the evolution of EMS, emergency medical services in the country. In the 50s, 60s, and 70s, it was just a ride to the hospital. Right. It was a ride in a vehicle you could lie down in,
Correct.
But often not even an attendant in the back with you. Right. There was no EMT back in the early days, and
right.
the EMT program began in the 1970s. That sort of started the beginning of what you might call EMS version 2, where there was some care delivered. At least you had someone trained with you, and you could begin to deliver care. And we're entering now really version 3 of EMS, where we're delivering very advanced care in the field, and as you mentioned, care that's based on research and data, as Jason mentioned. With the transition to electronic reporting, electronic charts, we can now gather nationwide millions and millions and millions of encounters with patients in the EMS system, and this is all kept in a national database, so it's available for research and feedback on what's working and what isn't. And as you mentioned, we try to base as much as we can in medicine on the best evidence. There are certainly things that have not been researched and are still based on consensus, and many of those things are just common sense, but the best we can, we try to use research, look at the outcome that's best for the patient. So in the protocol area, and for people who don't know, We have rules and regulations and laws that guide the EMS system, not just in Rhode Island, but in all states in the country. And in almost every state, there is a system of guidelines or protocols which come out in written form, sometimes in a flow chart form, that say, for this kind of complaint, these are the first 3, 4, 5 things you should do. And they advance through the different levels that Jason mentioned. So the EMT, the advanced EMT, cardiac, and the paramedic will have increasing things that they can do for the patient in certain situations, and then they can involve consulting a physician at the hospital for what's called medical control or medical direction. So when you get to a more advanced decision, where more physician judgment is necessary, therapies that may be sometimes with higher risk or require more decision making, you want that physician input. So in the latest set of the protocols, which are in the process of being released, we've made a lot of revisions in the format and the layout, the way that they're set up, and we are trying to be consistent with what's going on nationally in a national system of guidelines, and in format and eventually in content with all of the states in New England, so that not only people traveling around New England can experience the same care, but the EMS professionals who may live in Rhode Island but have a part-time job in Mass or Connecticut don't have to experience an entirely different way of delivering care. So this new protocol rollout includes lots of changes. One of them is in the area of sudden cardiac death or sudden cardiac arrest. And in that area, the biggest change that I think people have been talking about is the function of important and focused resuscitation at the scene of the incident. And this would begin with people in the general public taking CPR courses, learning how to do resuscitation, with dispatchers in the 911 system can instruct in how to do CPR over the phone, knowing if there's an automated defibrillator in the area where it may be located, bringing that to the scene, calling for help as soon as possible. The goal is to get resuscitation to that patient as quickly as possible after the emergency starts. So the ideal would be rapid recognition, bystander CPR by a trained person or someone trained over the phone to do the compressions, and that's the most important part, and then getting the defibrillator there quickly if it's something that's indicated for that patient. The automated defibrillators will figure that out. You have to have bare skin to put the defibrillator pads on, so a little bit of privacy is warranted if this happens in public. And then as the 911 system is activated, then you'll get advanced care, probably from a first response piece of fire apparatus, and then with an ambulance arriving. That's fairly typical in Rhode Island, although there are some communities where it differs. And the change that is in the new protocols is to focus on care at the scene, because studies have shown that delivering focused, concentrated, good quality resuscitation at the scene is the best thing for survival for the patient.
Now, Chief Rhodes, as you know, we both practice in the street, and people would say, hurry up, get him to the hospital. But this is a whole new evolution for our pre-hospital care providers. So why don't you explain to the public that they're going to, if something was to happen to a family member, friend, or even public, the pre-hospital care providers are going to be spending more time, because, and you've got some success stories to tell us in Rhode Island, which is good. So why don't you explain, because you're probably going to get the complaints. They're going to say to you, they were here, if they would have got them to the hospital sooner, and people, they have the right to obviously explain their concerns, but why don't you explain how you got the data, you worked with Dr. Williams to put this together.
Sure, so absolutely. So it's critically important now. We've certainly seen across a variety of studies, also a recommendation of the American Heart Association, which obviously is a high-level organization providing tremendous advice. So folks will see that if there's a medically related cardiac arrest, sudden cardiac arrest in a home of a friend or a family member, I first want to mention how important what Dr. Williams said, that bystander CPR and knowing how to do CPR and keeping calm and be able to provide some care prior to the arrival of the EMS and police. Certainly a lot of communities send police ahead or at the same time, and they may arrive first. So it's a continuum of care. Certainly. So it starts with bystander CPR. So if you don't know CPR yet, now to get out there and learn how to do hands-only CPR is a perfectly acceptable alternative, because we've seen in the past where people were afraid to do mouth-to-mouth or those kind of things. So hands on the chest, continuous chest compressions. We're doing an awesome, great thing for the community. However, once the first responders arrive, it is very important for them to be able to concentrate and perform what we call high-quality CPR. You cannot perform high-quality CPR when you're trying to take somebody off the 3rd floor on a backboard, putting them on a stretcher, wheeling them to a truck, and then trying to do chest compressions in a moving vehicle. Those are not high-quality compressions, and quite frankly, the success rate for resuscitation drastically drops because we're not staying and concentrating and doing those good, high-quality chest compressions. You'll see plenty of people there. The recommendation is that we switch compressors every 2 minutes, again, to continue to provide high-quality chest compressions. If we have somebody who just stays on the chest and tries to do compressions for 10, 15 minutes, they get tired, and the quality wanes very quickly. So having lots of people, the common terminology now is a pit crew mentality, where you'll see somebody who's in charge of the scene and probably not putting their hands on somebody, but just making sure the AED is applied properly.
Directing.
Right, they're the director, they're the chief, they're whatever role they're in. Making sure that we're switching every 2 minutes in a coordinated, organized fashion, and again, keeping the compressor's hands on the chest as much as absolutely possible. Advanced care will still be provided on scene. IVs started and medications administered, which is pretty much the same that would happen in the hospital emergency department. The same medications are being administered, the same CPR is being administered, the same electrical therapy is being administered.
That's another thing, Doc. As an emergency room physician, I don't think the people realize out there that now, because we've evolved, and I'll probably use that term several times in the show, but what the pre-hospital care providers are doing in the field, it would be almost a similar, I mean, obviously they're not doctors, we understand that, but basically, it would be the same thing in the emergency room. Is that correct to say, Doc?
That's very much correct to say. The most important thing for a person who suffers a medical cardiac arrest is good quality compressions and early defibrillation, and that can now be delivered by a layperson, bystander, any kind of first responder, police, fire, or otherwise, and then the ambulance personnel when they arrive. It's no different than the treatment that we perform in the emergency department. The next step would be to provide some kind of airway support and oxygen. Again, that can be easily delivered by ambulance personnel wherever the cardiac arrest occurs. There are some medications that may be beneficial for certain causes of cardiac arrest, and so people witnessing this kind of resuscitation will see an intravenous line or what's called an interosseous access device, which is a needle that goes into the bone, either in the shoulder, the breastbone, or in the leg, and medications can be injected in there and fluids can be injected in there, just like an IV that you might have seen in the hospital. But those medications are not the cornerstone of therapy, and there's no special treatment that we have at the hospital that's really different unless we get very far into the resuscitation and we find a very unusual medical cause that requires special treatment at the hospital, and those situations are very rare. For the patient to have the best chance of survival, they need to have good CPR as quickly as they can, and that means compressions that are the right depth and the right rate, which, as the chief mentioned, is very hard to do if you're trying to move someone. You're trying to compress about a third of the depth of between the front and the back of the chest. That takes a fair bit of force in an adult, and at a rate of about 110 compressions a minute. So people say you can kind of sing to yourself the song Staying Alive. If you take a CPR course, and you can do this online now with the Heart Association or the Red Cross, and go right on the internet and search CPR training, they'll give you some idea of how to do that. That's very important to do in an optimal manner. Every time you pause those compressions for just a few seconds, all the blood flow in that person's body stops.
Would you explain that, Doc? If you could explain it in a simple fashion to the audience, and then I want to go back to Chief Rhodes about, obviously, people are going to expect to see someone stay 30 minutes, but why don't you explain when they're compressing the chest exactly, in a simple form, what it's doing?
Sure. So we all know that our hearts are squeezing, and the heart's made of a muscle, and your heart is squeezing the upper chambers and the lower chambers, the atria, the ventricles, lubbed up inside your body. If you suffer cardiac arrest, that stops, The heart may be quivering or fibrillating. That's why we use a defibrillator to fix that. But it's not pumping blood. And when we push the chest for compressions, we're squeezing the heart between the breastbone and the backbone and squeezing to pump the blood out. Obviously, it's not a full output from the heart because it's not the way the heart's designed to work. So we're getting maybe 20-30% of the typical cardiac output when we do compressions. So you've got to do the best possible compressions at the rate that's been studied, that we know is the right rate. And it takes, as the chief mentioned, a fair bit of effort that fatigues people pretty quickly. There are some mechanical devices that can help, but they take a minute or two to put on. And so we need to coordinate that process as well with a lot of people at the scene. So good quality compressions from a bystander, good quality compressions at the scene to give the person the best chance of survival.
Great. One quick question before I go to the chief. Do you recommend, it's been brought to my attention, the people that have a history of heart disease, do you recommend, because people have said, should I buy a defibrillator or can I buy a defibrillator? Can people purchase a defibrillator for home use, if you will? I would assume with a doctor's order. How would that work?
That's correct. So the first thing I would recommend is that the family and friends take a CPR course.
CPR course, correct.
Because learning how to do the compressions, learning how to call the 911 system is the most important thing that you can do. If you do have a situation where you want to have a defibrillator, and some people maybe live a couple more minutes from help, or they have a boat and they're going to be out in the bay, it is possible to get one. It is also possible to lease or rent them.
Okay.
I believe you need a physician's order for most sources to acquire them, and they would run several hundred to $1,000. So it's not a trivial purchase.
No, but it's a human life.
But in someone who has a history where it might be important to have one handy. The other thing to know is that some people who've suffered cardiac arrest and survived have an implanted defibrillator.
That's correct. Yes.
So you may run into a person who says, "Oh, I've got a defibrillator. It's built right in the area where a pacemaker would be in the upper chest." And so there are people out there who have defibrillators built in. If you don't have either the financial ability to get one or don't want to get one, then you should learn where they are in your community. Or in police cruisers, is there one in a public building near you? Is there one in the library, the town hall, the nursing home, or when you travel at the airport, that sort of thing, in the schools? Learn where they are and learn where you can access one.
So now we know that we're going to see an increase, if you will, to Chief Rhodes, that increase. Now, we've had success stories in Rhode Island from people spending 30 minutes on scene or even sometimes less. Why don't you explain that? And when we spoke, you told me about this, and I was like, wow, that's fabulous. So we already have success stories.
Sure, absolutely. So
it does work.
Absolutely. So we have some very aggressive agencies who have said, this is a current recommendation of the Heart Association. So even though our protocol revision hasn't technically taken effect yet, it's still a best practice.
Yep.
So they've taken that approach, which we certainly applaud.
Yeah.
And we've had, 6, 7, 8 stories that we know of already.
Wow.
Where, and the common theme was the resuscitation occurred, the return of circulation occurred somewhere between the 20 and 25 minute mark.
Wow.
So that's a very significant number because if you had just hauled, as you mentioned earlier, quality CPR would not have occurred, and that return of circulation would most likely not have occurred. They needed 20 to 25 minutes of good quality CPR in place with the ability to concentrate before they returned to spontaneous circulation. And quite frankly, one of the best story we heard so far was the first story, where the team arrived, fire engine and ambulance, working together in a coordinated fashion. They achieved return of circulation at about the 25-minute mark, and this was in a younger person. They then were able to do a 12-lead EKG in the street, transmit that to the hospital, determine the best hospital to go to based upon the fact that they saw a heart attack going on. We're able to quickly get that person to the hospital and then into the cardiac catheterization lab. Have that blockage removed within 10 to 15 minutes of arrival, and that occurred on a Friday, and the person walked out of the hospital on their own power on Monday.
That's amazing, huh, Doc? Well, years ago that wouldn't happen. You've been this a long time.
And we're part of the thing that's driven this is that we're hearing these stories from around the country and the ability to gather that data, and that's why this recommendation has come out. the amount of time on the scene is not really all that different than what's been going on.
Correct.
Except that the focus in the past has been doing the resuscitation and moving the patient. What we need to do now is focus on the resuscitation for 30 minutes, and then if we get return of circulation, assess the patient, determine the best destination hospital, and transport them carefully to that hospital. Rushing and rushing and rushing makes it impossible to do good resuscitation. You can't do good compressions if you're carrying the patient down the stairs or if you're heading down the front steps. You can't do them if you're driving quickly in an ambulance. And so you need to stay on scene and do the good quality compressions, and then determine the best hospital to go to.
So you're perfect as our medical director. We've seen success stories, obviously. So people are going to probably see this, and hopefully, like I said earlier, hopefully they won't. But it's a part of life. We know that. By the way, Doc, we spoke about it off camera. That heart disease in this country is one of the leading causes of death. Is that a correct statement?
It is, and what we're really focused on here is sudden cardiac arrest.
Correct.
Not an expected death in a person who is in hospice care or in palliative care.
Correct.
But someone who suffers a sudden cardiac arrest, most often from a heart attack, sometimes from a couple of other causes that can be treated. And so in a medical situation, we're not talking about trauma here. We're not talking about car accidents or shooting or stabbing or falls. We're only talking about medical problems. The treatment in the field is very similar to the treatment in the hospital, and that's why this new protocol works.
And now we're seeing a lot of the heroin overdoses. Obviously, people going into respiratory, they go into cardiac arrest, and now with using obviously the Narcan, which we used years ago. I mean, that's where the public is seeing more of it, and there's more public use, which I also think is a good thing. So people are going to expect to see sometime. Now there'll be times, let's be honest, where a person may not make it, and that person, the family members can't blame the pre-hospital care provider saying, hey, if you would have gotten them to the hospital sooner, they might have been alive. That's not necessarily true. So is it okay in me saying that they've gotten every possible care that they could have got, even if they were in the emergency room, on scene? Now, as you know, Chief, some people, they're dead before they hit the floor. They have a massive MI. They might have had issues, and so they may not be resuscitated, but still, our pre-hospital care providers are still going to be required by protocol to do that 30-minute CPR, because there's a chance they may bring them back.
Right. There are various things that can be used to predict the chance of survival. The most important ones are the rapid recognition that the person has collapsed, and starting that bystander CPR, and then the initial rhythm that the heart's in. So if the heart is in one of those rhythms that a defibrillator can be used for, either ventricular fibrillation or ventricular tachycardia, they have a much better chance of survival. If the heart is entirely stopped, what's called asystole, or it's been many minutes since they collapsed, they found in bed, or somebody doesn't see them for a while, their chance of resuscitation is much lower. So, of course, this new protocol is not going to bring everyone back.
Absolutely.
But it has a much better chance for the people that have a chance of survival. So the people that have a witness collapse, who have one of those rhythms, get bystander CPR, their chances are much better with a focused effort at the scene.
Well, Chief, you've already experienced it in Rhode Island, in several communities that people have been brought back. With that new protocol, spending at least 30 minutes on scene with good quality, effective CPR.
Absolutely. So I think a common theme we've seen so far, Mayor, is that we've both mentioned several times is bystander CPR.
Bystander CPR.
And if you do anything in this holiday season, take an hour,
CPR.
Learn how to do hands-only CPR, and that's a gift to all your family and your community.
Absolutely. And they can call, they can call your office. I know that the community college office, they have a CTC. There's other CTCs. They can call Rhode Island. Why don't you give them your office number, if you would, where they can contact if they have any questions on it?
Sure, absolutely. So our number is 222-2401, and that's the Center for Emergency Medical Services at the Health Department.
Right. Doc, I'm sure you strongly recommend lay people taking a CPR course?
Of course. And you can call the Department of Health for referral, but you just go online on Google or whatever you use to search CPR course, Heart Association or Red Cross, and find out where there's a course in your community.
Great. I want to thank you both for coming on. This is a very important issue. Could affect any one of our fellow Rhode Islanders, as well as people coming into our state. I'd like to get you guys back here and talk about the Comfort One someday, because I think that's something that needs to be put out there. But thank you very much for coming on. Ladies and gentlemen, once again, I hope this was very informative to you. Until next time. I'm Mayor Joseph Polisena, keeping you informed. Goodbye.